I could talk about this stuff for forever. And so I guess what I'd like to start off with is interrupt me if you have questions, because I get super excited and probably can ramble on. I am going to share some slides. Let's make sure I can get this. Can you see my slides, or can you see my, oops, I think you need to share. Hold on a second. I think that after all this time, I should be able to do this.
There you go.
There we go. Okay. So I'm going to talk today about a recently completed trial that we did with funding from National Institutes for Nursing Research. And it's recently, we recently completed it, and we've been finishing up a bunch of the papers that go with it. And I think we're now at the point where I feel like I can tell a story, like a comprehensive story of why everybody should do this. And so maybe I'll convince you of that. Maybe I won't, but I hope I can kind of at least make some headway into having people think a little bit more about this. So I'll talk a little bit about this world of caregiving science, and which is a priority area for National Institutes on Nursing Research. I guess I should back up and just say I'm not a nurse. I'm a social and behavioral scientist trained in public health, and I've been at Mayo for almost 11 years. And before that, I was at the Minneapolis VA, and I was there for about 13 years. So I've had two very different health systems that I've worked in, and have had two very different sets of experiences in working with family caregivers, which has really been my focus of research and interest for like the last 15 years or so. And I got in this area because I've been really interested in women's health, and because the majority of caregivers are women. I was originally really interested in it from the perspective of work and unpaid work compared to paid work, and how women balance out these demands that they have for both the paid realm and the unpaid realm. But when I was working at the VA, a lot of this kind of went into the informal care setting with veterans returning from Iraq and Afghanistan with brain injuries. So there's been a lot that's developed in the world of caregiver science in the last 15, 20 years. So I'll talk a little bit about that. This is usually not a hard thing to sell people on, especially nurses who are in it every day and see the experiences that caregivers have. But I'll talk a little bit about the demands that caregivers have, their contribution to patient care. Then I'll talk a little bit about the trial and some of the next steps. And the next steps really have to do with some very exciting policy that has been happening in the last 5 years or so that are breaking down a lot of the barriers that we've faced in working in caregiving research and trying to integrate caregivers more into patient care. I don't have any financial conflicts to disclose, but I did want to mention that we did have this funding from NINR, and the trial is registered. And if anybody wants to go look it up, you're more than welcome to. At the very end, I also have a list of papers that we published off the trial too. So if anybody's interested in any of those, I'd be happy to send them to you. So what is this caregiver word that we use? It's a word that often doesn't resonate with caregivers. Caregivers often don't identify themselves as a caregiver. They say, I'm the spouse, or I'm the partner, I'm the daughter, or however the relationship role is that they have, but they often don't use the word caregiver. As researchers, we tend to use this as we identify or define caregiving as the provision of unpaid personal services that help patients meet or maximize their highest level of function. And to do that, so it can be direct services, it can be support, it kind of wraps in a lot of different things. And the people who provide this type of support, we call caregivers. It can be family, it doesn't have to be family, it could be a friend, it could be a neighbor. We typically use the word family to differentiate from healthcare providers, who are often called caregivers as well in different settings. this term informal caregiving or informal caregivers often used too. Caregivers hate that word because they identify as what they do as being important and not informal. It's something that they spend a lot of time doing. So we've tried in the field to try and steer away a little bit from using the word informal caregiving. And that was to compare to formal caregiving, which is typically paid caregiving. So my number one takeaway is that this is incredibly prevalent. Caregiving is most people will either have either been a caregiver, are a caregiver, or will in the future will need a caregiver. And so it's going to touch everybody's life at some time, probably, and most of us probably have been in that role. So it's not something that is rare or unique. It's a role that often we are thrust into, and sometimes it sort of develops over time. But we know that over 52 million people in the country are caregivers, and they provide care to an adult who is either disabled or seriously ill. And a lot of these caregivers are older, and as I mentioned before, most of them are women. And so this is an issue that's really prevalent or a really important issue for women's health. And I think something that often gets looked over as one of the common stressors that you sort of age into. The hours that people provide care really varies by the condition. And, I think the ones that are the most commonly described in the literature and probably in the news too are around Alzheimer's disease. There is a story in the Star Tribune this weekend on caring for people with Lewy body dementia. And it can be a 24/7 hour job, or it could be a couple hours a week where you're providing, shopping, or you're making appointments for somebody. So it really does vary, but the number of hours that a lot of caregivers put in is equivalent to at least a full-time job. So sometimes people are dealing with a full-time job and then their other full-time job, which is caregiving. So caregivers affect the outcomes that are important to healthcare systems. We know that caregiver engagement close to the discharge of a patient in the hospital can reduce admissions at 90 days and 180 days. It can reduce shorter hospitalization. It can lead to shorter hospitalization days. It can lower costs for both post-discharge care. So these are things that are really important to hospitals and to healthcare systems. And we know that if you actually engage and work with caregivers prior to discharge, that these things can be improved. We also know that there's a growing body of literature that shows that inpatient and outpatient care can be improved by engaging caregivers and improving the quality of life and the safety and the care management of patients too. So it's not just cost related, there are some tangible health benefits as well. And while caregiving can result in positive outcomes for caregivers, the relationship can get better. You can sort of spend more time with somebody. We also know that there's a lot of negative outcomes that come with caregiving as well. Some of these have to do with, poor self-efficacy. People avoid taking care of themselves and doing their own self-care, putting off appointments. So there's a lot of things that caregivers can gain benefit from, but there's also a lot of things that can actually affect their health, both in the short term and the long term. This is always a shocking statistic to me that if you looked at the costs related to unpaid caregiving, it would be $600 billion a year. And this has been a study that's been replicated every 5 years, and the costs just keep growing. We know that so in 2021, it was 600 billion. In 2017, it was 470 billion. So this is like a 25-year trend of increasing economic value that caregiving has. And without caregivers, our healthcare system really would collapse. We really do depend on this uncompensated, unpaid for care that caregivers provide. So what are some of these negative health outcomes that are associated with caregiving and caregivers? So we know that caregivers are at higher risk compared to their non-caregiver partners for depression and anxiety, for burnout, for memory deficits and cognitive decline, and for stroke. And we also know that there's a lot of social isolation that goes on. I think that's one of the main things that's been coming out in the literature and in the newspapers lately is the epidemic for loneliness is across most aging communities, but among caregivers, it's really stark. We know that it can cause a lot of marital and family discord around decision-making and hard, crucial conversations that have to happen and sometimes don't go well. And sometimes, sometimes relationships weren't good to begin with. And then a family caregiver is required to provide care to a family member that they've never really gotten along with. So it's not just the benevolent caregiver that sweeps in and does all this good work. Sometimes it's a very difficult relationship. And finally, caregiving can be related to a downward spiral in poverty. I think that if patients have extremely expensive costs and there's financial toxicity associated with care, such as cancer care, those costs can be absorbed by caregivers, especially after a patient dies. So it is potentially a very long-term impact on a caregiver's life. So with that sort of picture and larger perspective, I'll tell you a little bit about this trial that we just completed. So this was a trial looking at transitional palliative care, and it was the protocol for this, and the original grant was written by a colleague of mine, Dr. Diane Holland, who is a nurse and was a researcher at Mayo for many years. And she wrote this great grant, and it got funded. And as soon as it got funded, she decided to retire. She said, "Hey, will you step in and do this?" She was historically a discharge nurse and was really interested in the impact of discharge planning, and knew that I was a caregiving researcher, and so we were good partners. And so Diane stepped down from the principal investigator role. I took that on, and then after a few months, Diane came back and worked as a co-investigator on the study. So we still were able to learn from her expertise. So the study, as Diane first wrote it, was really around this double transition, the transition from hospital to home, or out of the hospital, that transition, which we think a lot about, especially as a discharge planner, as a time period that's really fraught with risk. It's at risk for patient safety. It's at risk for escalation of symptoms. It's a problem time for medication management. But the area that she was also really interested in was transitions for patients who are undergoing palliative care, or who had experience with palliative care in the hospital. So it's a shift in the model of care for caregivers to kind of get their head around what this new model of palliative care and symptom management is about, as well as a shift out of the hospital. So both of those transitions together end up being a lot of responsibility for caregivers. We know now that there are a lot of expectations that are put on caregivers to take up the slack and manage a lot of the care plans that happen after discharge. And that those responsibilities that caregivers are often given are done without a lot of training. There might be discharge planning and a little bit of training at the point of discharge, but not a lot that continues during that transition period. So caregivers are at risk for not really having the proper training and not having the proper support that they need during this critical time in a patient's transition. We also know that caregivers who are in rural areas have far fewer resources, especially when it comes to palliative care. They have fewer resources for support because they live long distances. They have a harder time getting to clinics for emergency services or for palliative care services. So there's a lot of additional stressors that rural caregivers face that their urban counterparts don't necessarily face. So the aim of this trial was really to try and bridge that gap for caregivers during this transition time. And we focused on caregivers because in our pilot work, we found that the caregivers were doing a lot of the transition care because the patients were not able to at that time. They were still sort of working through a lot of the difficulties and because getting back to being ambulatory, and they weren't really managing their own meds, so caregivers were doing that. So the trial was focused on the caregivers with the intention that this would be a strength-based intervention that would look at the strengths of the caregiver, build on those strengths, and really try and help them promote their own self-care. And it became clear pretty early on in the trial that we really had to kind of focus on two things, both the transition for the patient and the caregiving aspect of care, as well as the self-care. So it sort of had this dual purpose. So the trial was a randomized control trial, and we wanted to test the efficacy of a new intervention that included video visits. And we thought that this would be a great way to reach out to rural caregivers using video instead of having them come into the clinic or into the back into an outpatient setting to receive support and help with that transitioning care. So if you use video and you had like eyes on the caregiver and could build rapport that way, would this benefit the caregivers more than people who didn't have that kind of support? So it was a video-based intervention that caregivers met with nurse partners who were assigned to them prior to discharge. I'll talk a little bit about that. And what we hypothesized is that this type of intervention would improve both the care quality, meaning the preparedness that the caregiver had for their caregiving role, and their ability to communicate with clinicians during that transition, and then improve their well-being. So would it improve the caregiver quality of life? Would it reduce their burden? Would it improve depression? Would it improve the care recipients, which I tend to move into once the patient has been discharged from the hospital, I call them a care recipient. So would it improve their quality of life? And finally, we wanted to know if this type of intervention would actually reduce direct and indirect costs of care. So those were our hypotheses. And the way the study was designed is that we identified caregivers, and once they were recruited into the study, they were randomized either into an intervention or a control arm. And if they were randomized into the control arm, they received a phone call once a month for 6 months to, actually we were collecting the cost data for the AIM-3. But we felt that any interaction with our team could act as an intervention. And so we consider this to be sort of like a friendly phone call as well as collecting data. So they did get some attention during the trial. The intervention group met with the nurse partner prior to the patient's discharge, and either in person or over video. Before COVID, it was in person. During COVID, it was on video. And then once the patient was discharged, the nurse would meet with that caregiver twice a week for the first month and once a week for the second month. And then we assessed their outcomes. So the way that it worked is we had 4 hospitals in the Mayo Clinic system. 2 of them were in Rochester, both Methodist and St. Mary's Hospital in Rochester. And then we also recruited people from Mankato and La Crosse, those hospitals, so more of the community-based hospitals. And any patient who had received a palliative care consult was over the age of 21 and didn't have an LVAD or a history of chemical dependency, their caregiver was eligible if the caregiver lived in a rural area, and a rural area was defined as an area less than 50,000 people. So if that patient received the palliative care consult, we looked to see whether the caregiver lived in a rural area. We called them, asked them if they were interested in participating in the study. And if they were, we consented them into the study, and then the nurses would start meeting with the ones who were randomized into the intervention arm right away. And then they followed them over time. So the participants were living in rural areas in Minnesota, Wisconsin, and Iowa. And again, they were caring for somebody who had received a palliative care consult in the hospital and were transitioning home or to another facility. So we did have a number of people who discharged to a SNF or a rehab hospital for a short period of time and then went home. And so those people were also eligible and included in the study. But the way the intervention worked with the nurses, the nurse partners, is that they would identify, so they would talk to the caregiver, and we used the Omaha system. And I don't know if people are familiar with the Omaha system, but it was a way for us to identify unmet needs using this documentation system. And then with the Omaha system, you could identify the targets for intervention as well as pathways. And so we had certain pathways that we could follow based on what we would assess using the Omaha system. And we documented all of that in Nightingale Notes, which is a cloud-based EHR system that uses the Omaha system as its backbone. So everything was documented in Nightingale Notes, and the nurses took meticulous notes during these calls so that we had a record of what actually went on. And the majority of these calls had to do with caregiver support, strategies around care management, a lot of bereavement support, and I'll talk a little bit more about that when I get into the findings. We did a lot of extension of palliative care principles and worked on symptom management and goals of care. And then we tried to work on things on preparation for new transitions, such as either a transition towards the end of life or to a transition to a different type of caregiver, anything that was going to change in the patient's life. We worked on that. But we really tried to keep the focus on the caregiver and not necessarily on the patient. And that was a little tough to do. We usually spent the first, as I said, we had 8 weeks of intervention, and the first month we ended up spending a lot of time working on caregiving tasks, looking at pain management, breakthrough pain, how do you manage those things? And then the second month, we did a lot more concentration on caregiver self-care and the strengths-based approach that we had for that. So I'm going to get into some of the weeds, and I'm going to talk a little bit about the outcomes that we had, and I'll give you some caveats as I kind of go through those. And please feel free to come off mute and interrupt if I'm not explaining things well or if you've got questions. So as I said, aims 1 and 2 were really looking at care quality and caregiver well-being, as well as the care recipient well-being. And we collected data from the caregivers prior to the patient's discharge. That was sort of considered our baseline data. And then at 2 weeks after discharge and 8 weeks after discharge. And what we wanted to do to look at the intervention effect was to see if things changed between baseline and 8 weeks, and if that change was different between the intervention and the control group. So for care quality, we looked at preparedness and communication. For well-being, we looked at depression, burden, and quality of life for the caregiver. And we also looked at the caregiver's report of the care recipient's well-being. So that is a little bit of a caveat that I'll get back to as well. And then for the cost data, as I mentioned, we collected costs once a month from the control group. We also made those phone calls to the people in the intervention group and collected costs as well. So everybody received a phone call once a month from one of our study team who happened to be a social worker and was like one of the most empathetic and amazing people. So hence my worry about this being a little bit more of an intervention than just a straight up control. But she collected the cost data for us once a month for 6 months. And these were the costs of everything from the hospitalization to 6 months post-discharge for us to better understand how this type of intervention could affect costs. And we used a tool called the ambulatory and home care record to collect those data. Now, the analysis for the cost was done by a colleague of mine, Ristana Kaufman at Duke. And I'm going to present those findings, but I'm going to tell you that I'm no health economist. And I can give you a summary of the data and the take-home points, but if you ask me about the methods, I might fumble a lot. So that's just my caveat, that I will present those data because I think they're super interesting. But if we get into the weeds, I might not be able to answer all your questions. So for the data analysis, we took a look at all of the variables that we wanted to, that we thought might affect a transition in care. We wanted to look at the severity of the patient outcomes, or the severity of the patient's condition, how many comorbidities they had, what the risk for their mortality was. We wanted to look and see whether they had a good relationship with the caregiver, and all the demographic variables too. We wanted to look at those to see whether they were related to those outcomes that I talked about. And then once we had an idea of which variables were related to the outcomes, we started building statistical models to try and figure out what were good predictors of our outcomes. So I'll go through some of the outcomes now. So this is a really busy slide, and I apologize for that. But the take home for this is that the care recipients were predominantly white, and it's kind of a split between men and women. They were non-Hispanic or Latino. Most had some college education. Most were married, and most were receiving Medicare. There were no statistical differences between the care recipients in the control group and in the intervention group. And they were mostly around like 67 years old. So no differences between those two groups. Now, interestingly enough, when you look at the severity of the conditions that the care recipients had, these people were really sick. So on average, we calculate this thing called a Charlson comorbidity score to show how many comorbid conditions patients have. And a score that's greater than 5 means that they have a high risk for mortality. And the score goes from like 0 to 40. So it's a pretty big scale. But anything over 5 shows that they have a high risk for mortality. And our sample was 11.5. So these people were really sick. And in fact, 41% of them died before the 8-week period in the intervention was complete. So it shows you that the caregivers were going home with people who were really ill and had a lot of unmet needs. The most prevalent conditions for the caregivers were cancer. We had about 72% had some type of solid tumor or metastatic cancer. Renal disease and pulmonary disease were the other 2 most common chronic conditions that the care recipients had. As far as the caregivers, demographically not too different than the care recipients, except that they were younger. And I think that comes into play because there were a lot of children taking care of parents. But on average, they were about 58 years old. So we had more non-white participants in the control group than in the intervention group. But as you can see, it was so white. I mean, 94% of the sample was white. Those differences are probably an artifact of the data. And probably not going to tell us that much. But those were the only significant differences between the intervention and the control group was by race. It was a predominantly white, not Hispanic and Latino population with college education. Not too surprising, about 70% of the sample were women. But having said that, 30% were men, and that's a pretty high proportion of men in a caregiving study. And so it's an important thing for us to remember that men are providing a lot of services, and they are often overlooked. Their own unmet needs are often overlooked. Most of the caregivers were married, and most had private insurance. So as far as their relationship with the caregiver or with the care recipient, most were spouses, but there were a number of parents and children and other relatives. So, you know, these were not just adult children taking care of their parents. We also had quite a few parents taking care of their children. So really sick children who were in their 20s being cared for by their parents. Most were living together, and interestingly enough, about almost half had been caring for the care recipient for less than a year. So a lot of the tasks that they were doing were relatively new still, and had a lot of learning to happen, the learning that they had to do over that time. So our first outcome, and this is we've got a paper that's under review right now that talks about these outcomes. We found a significant change between the intervention and the control group in their preparedness for their caregiving role. So the intervention really had an effect on how prepared caregivers were between that baseline and 8-week period. We did not find a big change in their ability or their comfort with communicating with their clinical team, however, between the intervention and the control group. And so that was our first takeaway in care quality, was that the intervention improved caregiver preparedness. For the well-being, interestingly enough, we found a significant improvement in quality of life between the intervention and the control group. And we didn't find anything in burden. So no change, there was no change in caregiver burden between the intervention and the control group. And we ran 2 types of models. The unadjusted model is just, was the intervention associated with the outcome? And then we adjusted those models for things that possibly could explain the relationship between the outcome and the intervention. So this could be relationship quality, it could be the amount of time that they were spent caregiving, it could be the whether they had help in the house. So we had a bunch of variables that we controlled for. And when we controlled for those variables, we found that depression actually improved between the intervention and the control group. So the takeaway here is that after controlling for other variables that may be associated with the transition, depression improved in the intervention group, quality of life improved, but there was no change in caregiver burden. And then finally, as I noted, the caregivers reported the quality of life of the care recipient. And what we found here is that there was an increase in quality of life for the care recipient between the baseline and 8 weeks for the intervention group, but not for the control group. And that was both in the unadjusted and the adjusted analyses. And these outcomes paper, the well-being and the caregiver recipient quality of life, that's the paper that Kathy saw that I had posted on LinkedIn, and that was just recently published. So here's the cost stuff, and here's where I get a little bit jumpy, because I'm not as good at explaining this stuff as my colleague is, but I will give you the take-home messages, which is that the average cost, the value of what we calculated in these analyses, that the value of the caregiver's time and effort for the care recipient per month was about $10,000 a month. So a huge, huge amount of value that the caregivers were giving to the patient. So this is cost that is not being put on the healthcare system because it's being done at home. So that was a huge learning a big lesson for us was that this was a significant amount of time and effort. And those costs, the value of that time increased for caregivers who are caring for people at the end of life, which a lot of our care recipients were. We also did an analysis with a different paper to try and figure out how much does this intervention actually cost. So, we were using nurses who had palliative care training, and we wanted to figure out how much was the intervention costing, and if you used a nurse versus a social worker versus an NP, what would the difference in the cost be? So the base cost was about $400. So every person who was in the intervention cost about $400 for that person for the whole trial. So if you were doing it with a RN, it's about $400. If you were doing it with an NP, it goes up to about $600. And if you did it with a social worker, it was about $340. And this is based on average rates from the Bureau of Labor Statistics, not from what we pay people at Mayo. So it gives you a question of, okay, is this kind of model sustainable given those costs? So the next part of this study, let me go back here. Hang on to that for a minute. So because what we did is we found billing codes, and we found potential billing codes that could actually offset the costs of the $400 from the nurse that was providing the care. So I'll come back to that in a minute. But on average, the caregivers who were in the study were spending about $770 out of pocket during that 6-month period. It didn't differ between the intervention and the control group, but I think it is really important to note that there's a lot of money that caregivers are, paying out of pocket for this care that's not necessarily reimbursed to them either. And so there's additional costs that are often overlooked and really not addressed when we're looking at economic models for patient outcomes and patient costs. So the next set of analysis that I'm really excited about is that when we compared the intervention to the control group, we looked at all different types of healthcare utilization. And the healthcare utilization included everything from outpatient care to emergency room visits and hospital stays. What we found is that we had the people in the intervention group compared to the control group had almost 2 fewer nights in the 6 months in the intervention group, 2 fewer nights in the 6 months compared to the control group. So we were saving about 2 nights by having this intervention. So if you compare the 2 nights in the hospital versus the $400 for the cost for the intervention, things really begin to come into focus that there could potentially be a cost savings here. So what are the implications? So, I would take away that 1, video visits can extend palliative care visits. They can be used effectively in rural communities without compromising, quality of care. This individualized approach, I think, is really important. This assessing that we did every single time, assessing unmet needs and addressing those needs, is really a different approach than a lot of interventions, which are manualized and sort of have a protocol and a rigid protocol saying this is what you have to do. And I think that's one reason why we had such good outcomes, is that we really tailored the needs of the caregiver every single time that we met with them. I think that the outcome for the care recipients having improved quality of life is pretty interesting, given how sick a lot of these care recipients were, and that we have this non-pharmacological strategy to improve outcomes for this patient population is really helpful, but with the caveat that it could be that the caregivers actually it could be that the quality of life didn't improve, but the caregiver's perception of their quality of life improved over time too. So there's some things that we still have to kind of think about for the implications. And then the cost, again, those implications I think are pretty important. We know that there's a huge out-of-pocket burden for caregivers, and that it's really important to pay attention to those out-of-pocket costs, because I think that in rural communities, that's literally money out of their pocket. We reduce hospital nights in the intervention group, which means that there's a lot of potential for cost sharing and for reducing the cost of the intervention. And, you know, for a lot of the patients in the study who were close to the end of life, the decreased costs, which is, you know, at the end of life, we usually think of healthcare costs going way up. But the fact that we had decreased hospitalizations may signal that we had better end-of-life experiences too. So another thing to think about as we begin to formulate what we do next. So there's a lot of limitations to this study. I can go into those, but I really do want to get to the policy implications too. So I'll just note that there are limitations, and I understand that there are limitations, and there were a lot of challenges to the study, but let me kind of move on to the policy implications too, and we can talk about limitations if you want. So the take home is that we've got, you know, improved preparedness, improved depression and quality of life for the caregiver, improved quality of life for the care recipient, reduce costs, reduce hospital nights. And we've got this potential to, we know it's going to cost $400, but we have this potential to get reimbursement from CMS now using some new codes. Now, these codes are, there's a new set of training codes that CMS approved this in 2024 that now allow for caregivers to be, for providers to be reimbursed for training when caregivers are alone, typically before the patient had to be present. So there's behavior management training that can be done, and there's rehab training that can be done with only the caregiver present. So there's all these opportunities that we have now to actually affect reimbursement if we can kind of put the processes in place. We also looked at possible transitional care management codes and chronic care management codes to be used as ways to reimburse for these services as well. None of these things we put into practice because in the trial, everything was sort of taken care of, but we're beginning to think about what next steps could be and how we could put this into routine care so reimbursement becomes a question. I wanted to do a couple more things on policy. So a couple of the things that we're really interested in is identifying caregivers and assessing caregivers for services. And this has become a big national conversation. And in 42 states across the country, 42 states have passed what we call the CARE Act. And this was an act that was developed by AARP and then advocates within each state for AARP helped pass it. Minnesota has passed it. Wisconsin still has not passed it, but Minnesota has. And what the policy or the law says is that hospitals are now required to ask the patient upon admission if they have a family caregiver, and if they do or if they don't, to document it in the electronic health record, and then contact that person prior to discharge and do care planning and care transition education at the time of discharge with that caregiver. It doesn't sound like a lot, but in the caregiving world, this is pretty big stuff because we have very little, to this point, we haven't had a lot of time or a lot of ability to be able to identify caregivers in the record. The other thing is that we now have a national strategy to support family caregivers. This was published originally in 2022, and we've got updates in 2024. We have national strategies that are across all different departments and institutes in the federal government that are now tasked with identifying ways of improving caregiver outcomes and integrating caregivers into better integrating them into care processes and to providing better support. So it's a long document. There's a lot of different strategies. It's still relatively new, but there is a lot of momentum and a lot of movement in this area, which is exciting. And then last year, President Biden put out an executive order increasing the support for caregivers. And this was a charge for healthcare systems to better support caregivers, both for palliative care and for care management around dementia. And there were also some specific areas within the VA that they were supporting as well. So a lot of attention was and is being paid to caregivers at the national and at the state level. Getting it down to the individual health system level is a challenge, and I think that's where a lot of our work we're hoping to move forward. And I think that's what the next step in this study is to try and get it into routine care, and we're going to have to tackle some of these issues within the healthcare systems in light of the advances that we've made in policy. There's still some tricky things that we have to figure out in the health system side, like where are you going to document this? Are you going to document it in the patient chart? Are you going to open up a new caregiver chart? So there's all kinds of questions that we have to kind of work through. I know we're running out of time, and like I said, I can talk and talk and talk and talk about this stuff, but I did want to leave some time for questions. I do have a list of papers here that we've kind of covered some of the things that we've got in the papers, but if you'd like to talk more about those, or if you'd like to email me, I'd be happy to send you the list and you can peruse what might be interesting to you. And I'd be happy, of course, to set up a call if you'd like to talk about these things in more detail as well. But with that, I will end my talking and talking and talking and open it up and see if anybody has any questions for me. I'll stop sharing.
So I love this, and I keep on thinking about not just like the chronic care or palliative care, but as we talk about hospital at home and you know what the impact on family caregivers is going to be in that, and how to cost that out, because this uncompensated care model is just not it's not going to work.
I 100% agree. And I think, you know, the trends in care towards hospital at home and remote patient monitoring, all these things put extra burden on family members. And if you don't develop those systems with sort of a family-centered model in mind, you may end up with 2 patients instead of 1. And so I think we really have to be cognizant of what these advancements, which are you know, helpful in so many ways, and you know, I think can provide better patient care, but we don't want to do that at the expense of caregivers and undermining their own health so that they can't either care for the patient or they can't care for themselves. So I 100% agree with you. I think that that's a really important consideration for us to think about.
The other thing I was thinking about when you were talking was I heard Vivek Murphy talk about the epidemic of loneliness earlier this month, and the impact on family caregivers by just having someone check in with the routine frequency that you were providing in this study, and how not feeling alone in this was probably pretty impactful.
Yeah, I've often wondered, is it, you know, is it a friendly phone call? Is it enough to just do a touch point and say, hey, how are things going? What's going on? Or I mean, so I'm not sure about that. Is it a friendly phone call, or are there really important tasks that were managed? So I've gone back and listened to a bunch of the recordings that we have. And it's kind of a combination. There are some people who just really needed somebody to talk to. And then there were other people who were like, there's breakthrough pain. I don't know how I'm managing this. They've got morphine and I'm not sure if this is the right, I mean, so there were more complex
Right.
care management issues that were going on too.
Right.
If we
It's
can
like
figure out
our
a way to
patients that
screen
in the hospital, when we're taking care of them and they really need that care, but they really need you to be touching them at the same time because they're just,
exactly.
yeah.
Yeah.
Julia, you have a question.
Yeah, thank you so much, for such an excellent presentation. My question is about culture. When I was looking at, because I was listening with rapt attention, I was looking at, in your data collection, you talked about, more white people in this group, and that how are you able to share how does culture impact caregiving? I'm gonna use myself as an example. In my culture, it's hard for me to say, I'm tired, I can't do this because family expects me to. My mom is, she passed away this year. She was living with me. If I go put her in a nursing home to get some rest myself, people will see it as, what is she doing?
Yeah.
As an abomination. So I don't know how do you see culture play a part, in your study? I mean, I would like to have a copy of your present, PowerPoint, if you don't mind.
Yeah, absolutely. It's a really good question, and I think it's one of the things that we really struggled with. And I was, if you're dealing with rural populations in Minnesota, Iowa, and Wisconsin, I guess it's not too surprising that we had as high of a population of white non-Latino participants as we had. And we really have kind of sat down and thought, okay, so what's gonna happen, if we go into an urban setting or a more diverse setting? Because I think that we will be dealing with a lot of different cultural issues. I know that in a lot of cultures, it's not one caregiver, it's a family of caregivers. And you're not just, intervening with one person just doesn't make any sense because you've got 4 or 5 children or
Taking decision.
aunties or whatever who are around who are providing that care. And so how do you begin to tailor things in a way for multiple caregivers? Or, I've got somebody who's working on long-term care, and she's like, there's a huge issue around nutrition and diet. And she's like, because you go into a long-term care facility or into a SNF, and she's like, they're giving you like food that a lot of people don't recognize because that's not what they eat. And so we have so much work to do in trying to figure out how to bridge some of those things. And whether the models that we're using right now can be tailored to different cultures. I think that they can, because I think, like I said before, we're not using a manualized intervention. We are adapting the needs of the caregiver every single time we meet with them. And I think that one of the reasons like we had such an impact on male caregivers is because we addressed the needs that they had and didn't just assume that they were just like all the women in our study. So I think that the beauty of this is that it is adaptable. I think we would just have to have a better understanding of, we'd have to do a better job of really listening and understanding how to meet those needs, and probably follow the caregivers a lot more. I mean, they would probably have to guide the interventionists more than the interventionist guiding the caregiver.
Thank you. I like this.
Christy, did you want to ask your question that you put in the chat?
Well, I don't know. I can read it, I guess, but I was just curious about if there was any about the impact of socioeconomic status differences and access to additional resources. I understand that you were talking about there's varying access to resources in any communities, including rural communities, but then specifically also medical assistants or dual eligible folks. But when I was looking at your population, maybe there wasn't enough of that population, the subpopulation, to be statistically significant. But I was just curious if any of that came up. For example, folks maybe on waivers or having other, like other access to maybe paid help and stuff, and how that impacts.
So it came up a number of times and in a bunch of different ways. And the way that we worked on it is if it came up as an issue, like if there was, if it seemed that somebody was eligible for a waiver or eligible for VA benefits or things like that, the nurse interventionist would work with the caregiver and say, okay, we think that these benefits are going to be available and we'll walk you through it, but we need to. They weren't going to do it for them. They were going to sort of walk them through how to get those services and sort of guide them that way, but not necessarily. So it wasn't a social work intervention where they would go out and, help you fill out the forms and everything, but they would certainly guide you that way. There was one guy, for instance, who was a vet and was eligible for VA benefits. And really needed them because of medication benefits. And so she worked with the local veteran service officer and got this guy signed up. And then once, he was signed up, she, sort of handed it over to the caregiver and to work with the VSO on that kind of stuff. So they were navigators in some ways too. But it was, issues around food insecurity, which we had a lot of, they were identifying resources in the community. So they did act as sort of navigators in communities that they weren't necessarily embedded in because they were local, but they were not in Minnesota, Iowa. They were kind of had a broad range of places that they didn't have full understanding of what were the local resources.
Thanks.
Mary Tanner has her hand up.
Yes, I have I came up with a question and I see we don't have time, but what a wonderful topic that I wasn't familiar with at all. But I don't know if you know, but I have stuff to do with a lot of research, healthcare research. And I was wondering, as you were talking, how many of the people that you were talking about were also included in research programs, especially a lot of the, because of their illnesses, a lot of them were probably related to that. And I'm wondering, right, from an ethical perspective, if we need to talk about this in terms of informed consent documents and things like that, because a lot of sometimes parents for kids get to sign up for people to go into research studies, but other adults can too, partners, things like that. So.
Yeah. So I don't know, that's a really interesting question. I don't know how many of the care recipients were in trials. I assume a lot of them were. And I mean, if you're at Mayo, they try and sign you up for a trial because it's a research institution. But there aren't as many caregiver trials. So it's just paying attention to the caregiver. People were like, wait, you want to study me? Like I'm important? It was like a big deal for them to be included in a study. And people were pretty excited about the fact that this was paying attention to their needs, but there aren't that many. And so I don't know about whether the caregiver was trying to manage the patient's, eligibility and having to work on trials. I know that's a whole nother set of tasks that caregivers have to do. But I don't really know if they were involved in trials. They probably were. And I'm not really sure if it came up. It's a really good question.
Okay.
Yeah.
And
Yeah, from our research perspective too, what you covered. So another topic.
Yeah.
always topic. Martha was wondering too if any of the patients who had started with palliative care used respite care or had transitioned to hospice during the study.
Yeah, they did. And some people went home with hospice and some people transitioned to hospice. And we looked at that. It didn't change the costs. I know that for sure. It really didn't differ between the intervention and the control group, so we really didn't see any differences in the outcomes based on those who enrolled in hospice and the ones that didn't. But yeah, I mean, a lot of them did. It's interesting, like, so we had this discussion recently where we were presenting these data. So hospice, and I don't know if there's any hospice nurses on the call, but at Mayo, typically what happens is that, you know, hospice is involved and then is with you to the death, and then bereavement doesn't start for a month after. And so there's this gap in time between, you know, the build up to the end of life and then when bereavement starts. I think just giving people sort of time to go through, you know, funeral services and planning and paying bills and all the things that happen right after a death. So we originally designed this study so that it would stop at the time of a patient's death. And it became very clear to us very quickly that that was bordering on unethical, that we really couldn't leave people high and dry at that time. So we decided to change the protocol, and we continued with people until the full 8 weeks was done. So if somebody enrolled in the study and their loved one died after 2 weeks, we would stick with them for another month and kind of went through that bereavement period with them. But we kind of filled that gap between the time of death and when hospice would come in for bereavement. And we've got a paper right now that is under review because it seems like people shouldn't have to be left on their own for that month. It's sort of like this critical time for them to manage. And if you've got somebody who you've been working with prior to death, you've got that continuation of care. So it filled a gap that we really didn't identify before the study started, which I was really proud of. And I think that most of the people who had a loved one that died prior to the end of the trial continued on, and continued on with the bereavement part. And so it's one of those unexpected things that happened, but I think it was definitely, it was hard for us to measure because we didn't start off thinking that we were going to measure bereavement or grief. I wish we would have. Like, you finish every study and you think, oh, why didn't I do that? And that's probably the one that I would take away with this is, why didn't we measure grief? So
one of the panels that I'm helped organize that I'm most proud of was we brought together some nurse researchers, and we asked them not to talk about their research, but what they learned that they didn't expect to know. And it was a fascinating panel.
yeah, I bet.
Yeah, it's very cool.
Once you get past the I don't want to admit all my mistakes problem.
Right.
I'm happy to admit my mistakes because that's how you learn, and there's always a lot of them.
Yeah. Anyone else have any questions, comments before we call it a night? Getting a lot of accolades in the chat there. People are fascinated and happy to know about your research. So,
and if anybody would like to contact me offline or email me, I'd be more than happy to have the conversation.
great. Thank you so much, Joan.
Yeah, absolutely. Thanks, everybody. Appreciate it. Thanks for inviting me.
Thank you.
Thank you.
Have a great
Okay.
night.
All right. Bye.
Bye-bye.